Okay, we are starting chapter 21, orthopedic surgery, starting on page 890. You can see the case study is there on page 890 as well as the objectives. All right, and we will get started. Okay, so we are on page 891 on this slide. It's talking about table 21-2, and that you can see on, let's see, table 21-2. Um, on page 896, all the pathologies, which we will go through quite in detail. As you can see, this chapter is very full. This is one of the longer chapters only because we have so many bones in our body. And so there's, for every indentation, every groove, anything like that, we have a name for it if you can remember back to your anatomy. So on page 891 under bone and tissue, there you see the characteristics of bone, the living tissue. It does provide the form and the structure to the human body. So that second paragraph, second sentence, the skeletal system comprises the bones and other structures that make up the joints of the skeleton. Those other structures include the cartilage, tendons, and ligaments that hold the skeletal framework together. And then it talks about the following functions that the skeleton performs. I'm trying to get out my notes here while I'm talking to you, so bear with me. I haven't done this in quite some time. But I really want you to look at number 4. It serves as a source of red blood cells, or RBCs. So because it contains the red bone marrow, bone is one of the hematopoietic tissues of the body, if I can talk. Okay, so I'm trying to get all the words here. Here we go. The key terms, which I guess that I don't have either. Oh yeah, I do. There we go. All right, so in red you see cartilage. And what that is, I like to read the definition verbatim so I get it as close to what you learned back in your prereqs as possible. Cartilage is a non-vascular fibrous connective tissue that is located in the joints, larynx, trachea, thorax, nose, and ear. So it's that really wiggly area, not quite bone, not quite soft tissue. It's very cartilaginous. Which cartilage is cartilaginous. And so we want to understand that it's movable, it's flexible. And then in number 4, marrow. Marrow is defined as a semi-solid tissue found in the spaces of cancellous bone. There are 2 types, red bone marrow and yellow bone marrow, and we will talk more in depth about this. But just know that the yellow bone marrow is very fatty, very liquidy, very slippery, whereas the red bone marrow, very dense, more compact than the yellow marrow. Okay, so under bone tissue in that first column, that second sentence, bone cells are called osteocytes, and the surrounding matrix is made up of calcium salts and collagen. So make sure that you know what the bone cells, those osteocytes, are made up of. And then in the next column, you have, it's talking about the different types of bone. So there are 2 types of bone tissue. Compact bone or cortical bone, and cortical bone is a type of bone tissue that is hard and dense and that surrounds the marrow cavity, and so that's also referred to as your compact bone. Found within compact bone are the haversian systems, those haversian canals. A single haversian unit is made up of circular rings of bone matrix with implanted osteocytes that form a canal. And so we're now on the next page, but you can see where that compact bone is in that tissue in that picture, figure 21-2. So the compact bone, that's your cortical bone, and then it's pointing to the spongy bone, which is the cancellous bone. And so it says the haversian units are connected to make up compact bone and are not found in cancellous bone. Now, cancellous bone is a type of bone tissue found at the ends of bone and lining the medullary marrow cavity. It's composed of columns of trabeculae with large spaces in between. It's also referred to as spongy bone due to its appearance. So each osteocyte is found in a space or lacuna of the matrix and extends filament-like processes through canaliculi or canaliculi, I say canaliculi, microscopic channels called Volkmann's canals to contact adjacent osteocytes processes and the blood vessels. So again, cancellous or spongy bone is found at the ends of bone and lining the medullary marrow cavity. Cancellous bone gives the appearance of a sponge due to its porous matrix. So again, the yellow marrow is more prevalent in the cancellous bone than the compact bone. And this is going to really come into play when we get out that ORIF set. The computer cut me off a little bit, but what I was saying on that last slide is that when we get out the ORIF set here in a little while for our hands-on activities, I will help you to understand the equipment and the instruments and the implants used on these different types of bones. Okay, next paragraph. Surrounding bone is a thin fibrous layer of tissue called the periosteum. It is composed of two cell layers. The inner cambium layer is the area where new bone cells are formed. And then that last sentence, the periosteum also serves as a layer of defense against infection of bone. All right, so we're in the next column. First paragraph, bone contains large quantities of calcium. That's why they tell us to drink milk when we're little. Halfway down, when the body detects a low serum level of calcium, osteoclasts are stimulated by parathyroid hormone to break down bone tissue and increase the reabsorption of calcium from the bones into the blood, thereby increasing the circulating calcium level. Okay, so then the next paragraph, besides the effect hormones have on bone, three other important factors affect the growth and maintenance of bone. That is heredity, nutrition, and exercise. So the more we exercise, the more strenuous we are on our bones. That can affect bone growth. If you look at gymnasts, they're very short because they're constantly bouncing. They're constantly doing these little microfractures on their long bones, so they are short. Again, heredity. If your family has osteoporosis, there's a good chance that you may have osteoporosis. And then, of course, nutrition. Because our food, there's calcium in certain foods, your dark leafy greens, your dairies, and so if we have a low calcium level in our nutrition, we're going to have low calcium and poor bone quality. Okay, so now we're onto types of bones, bottom right hand in the second column. The long bones include bones of the arm, which is humerus, just like it says here on the slide, legs, which is the femur, hands, and feet for the phalanges. The shaft of the long bone is called the diaphysis, and the ends are called epiphyses or epiphysis for a singular. The diaphysis is composed of compact bone that surrounds the medullary cavity. The epiphyses are composed of cancellous bone. Now you can see on 893 there it has a great outline. I try to draw this on the whiteboard and my bone looks nothing like this. So you can see the middle part, that shaft where you would just naturally grab a bone is the diaphysis, and then the ends are the epiphysis. The epiphyseal plate is usually on, well, it is on top of the tibia, and so if a child has a fracture in the epiphyseal plate, that means they're going to have issues with bone development and growth there, so we have to address that surgically. However, I need you to write next to that figure, that 21-3, you need to write that hormone equals mineral storage. Hormone equals mineral storage. So if if all of our hormones are intact, we're going to be able to store our minerals just fine. Okay, so hormones equals mineral storage. All right, so back on 892, after second paragraph after we just talked about, oh, and in red where it says epiphyses, let me just define that. So that's the proximal portion of a long bone. Proximal, of course, meaning closest to the midline. So epiphyses, epiphyseal, epiphysis, it's all proximal to the long bone. The epiphyses make up the joint area of the bone. The joint surfaces are covered by cartilage called the articular cartilage, which in turn is covered by the synovial membrane. The combination of ligaments surrounding the joint and synovial membrane is referred to as the joint capsule. Okay. And then continuing on to the next page, that's first paragraph. Small sacs called bursa are located in many joints, such as the shoulder. The sacs contain synovial fluid, which acts as a lubricant to aid in joint movement. Next paragraph. At the epiphyses in growing bone, there is an area known as the epiphyseal plate, which we just discussed. This is the area of active bone growth. In the majority of growing bones, new bone is formed at the epiphyseal plate by the process known as endochondral ossification. All right, next paragraph. Short bones are the bones of the wrists, so those are your carpals, and ankles, which are your tarsals, just like what it says here on the slide. Next paragraph. The ribs, scapula, sternum, and cranial bones are example of flat bones. Now I have ribs and scapula underlined, and then I underlined flat bones. And then the next sentence on the right side, there's ribs and sternum, which I also have underlined. What I'm wanting you to understand and what it says in this slide so you don't forget that flat bones are the ribs, scapula, sternum, and cranial bones. Okay. In adults, the majority of RBCs are manufactured and supplied to the body in the ribs and sternum. Okay, the bones of the skull and face and the vertebrae are known as irregular bones. So if there's a test question that asks where do the majority of RBCs come from, ribs and sternum. And what kind of bones are they? Those are flat bones. So where is the majority of RBCs manufactured? In flat bones. Please make that connection. Sesamoid or round bones are found within tendons. The patella is a type of sesamoid bone. And fun fact, your sesamoid bone, the biggest one is the patella. Your patella is the biggest sesamoid bone that you have in the body. All right, so under there is the types of joints, and you can see all of them right here on the slide. The area where two bones meet to form a joint is called the articulation or articulate. That's why there it's called, where was it? In your reading, I want to make that little hyperlink there. Articular cartilage, so you'll have articular cartilage on top because it's in the joint. Where is it? Anyways, yeah, right there on 892, that second sentence in the second paragraph, the joint surfaces are covered by a cartilage called the articular cartilage because that means it's in the joint. So anything articular is in the joint. Joints are classified according to the movement that is possible. The three general groups are called immovable, slightly movable, and freely movable joints. So those are the first three on this slide. Next page, let's talk about them. Okay, under the immovable joints, a synarthrosis is an immovable joint, and an example is the suture lines of the cranial bones. Now, these are slightly movable in newborns up to about 2 years old. They have those soft spots. So we have the synarthrosis when we become more mature from like 2 and up. But for the most part, if they're talking about an immovable joint, that's a good way to remember it are your cranial bones. You don't want your cranium to move. Okay, an amphiarthrosis is a joint that is slightly movable. Examples of this type of joint include cartilage that connects the vertebrae and the disc of cartilage called the symphysis pubis that connects the pubic bones. And so what we talked about in OBGYN is how like the tailbone will straighten whenever the fetal head is coming out of the birth canal. It is because it is an amphiarthrotic joint. It is a slightly movable. It has cartilage. A lot of the female body has a lot of cartilage in that pelvic girdle because we have to deliver a watermelon-sized fetus, and so we need our bones to move. A diarthrosis is a freely movable joint. All diarthroses are also referred to as synovial joints because these joints all contain a synovial membrane that secretes synovial fluid. Okay, so these are any of the joints that we're about to talk about. The majority of them are diarthrosis or diarthrotic. Okay. All right, now you can see a wonderful diarthrosis joint at the bottom of that page, the periosteum versus where the bone is. You can see the joint cavity, etc., the articular cartilage, and all that. So whenever you need a key periosteal elevator, guess what tissue you're taking off with that? You're taking off that periosteum right there that's labeled in that white. Okay. Okay, so let's talk about the different kinds of joints. So the first one is the ball and socket joint. So this type of joint allows for the widest range of motion, and whenever we talk about ROM, we're talking about range of motion. Examples include the shoulder and hip joints. Those are ball and socket. So you have your femoral head and your hip socket, which is oh my gosh, I'm blanking right now. But anyways, you have the femoral head that goes into the hip joint, and then you have your humeral head that goes into the glenoid, which is your shoulder joint. Why can I not think? It starts with an A. It starts with an A. It'll come to me. Anyways, so yeah, shoulder and hip joints, ball and socket. Okay, anything that you can move, anything you can shake, that is a ball and socket. All right, the condyloid joints. It's going to drive me crazy now. The condyloid joint allows for movement in only one plane with some lateral movement. So an example is the temporomandibular joint, in which the condyle of the mandible fits into the fossa of the temporal bone or the temporal bone. Oh my gosh, what in the world is that called? I'm looking as I'm trying to talk and I cannot find it. Oh my goodness. Acetabulum. The acetabulum. That's what starts with A. I knew it. Acetabulum. Your femoral head fits into the acetabulum. Okay, now I can move on. All right, gliding joints. Gliding joints allow side to side and twisting movements. An example of a gliding joint is the carpals of the wrist joint. It glides. Very nice. Okay, hinge joints. The elbow is a hinge joint. This type of joint allows movement in only one plane, much like the motion permitted by the hinge of a door. Okay, so yeah, elbow, perfect example. Knee, perfect example of a hinge joint. Pivot joints allow only a rotational movement around a central axis. The joint formed at the proximal end, and proximal means nearer to the origin of a structure. The joint formed at the proximal end of the radius is a type of pivot joint. Okay, so next to pivot joints, you need to write proximal end of radius, which it talks about right there, and C1 and C2 vertebrae. Those two are pivotal joints. Okay, So because C1 and C2, it's your atlas and your axis, and it allows for your head to rotate. Those are pivotal joints. So the proximal end of the radius and C1, C2 vertebrae, those are your pivot joints. Make sure that you know C1, C2. All right, saddle joints. Saddle joints allow movement in a variety of planes. An example is the joint formed by the trapezium of the wrist and the metacarpal of the thumb. Okay. Okay, so you have a great box on the page on the end of 895. That table 21-1, the joint movement terminology. Make sure that you know each one of those. Those are critical for you to understand. A lot of times your orthopedic surgeon will tell you, I need you to abduct that arm. I need you to adduct AD, or they'll say abduct or adduct for ab or adduct. Rotate, excuse me, flex, dorsiflex, etc. So make sure that you know that. Okay, I'm going to try not to clear my voice so much. All right, so on 896, you have this massive table that we were talking about at the top of this, the orthopedic pathologies, and I would highlight orthopedic pathologies. So the first one that I want you to look at is that rheumatoid arthritis, or RA, and those are that's a very good example of the hands, what hands would look like if you have RA. So under the description, that second one, rheumatoid arthritis is considered an autoimmune disease, which is an abnormal response against one's own body. Okay, so and then further down, the disease starts with a simple synovitis and can progress through several stages, the last being joint immobility. Those that have rheumatoid arthritis, they're very painful. And the patient gets very frustrated because they cannot move that much. They can't do simple tasks like buttoning or unbuttoning or zipping. And so sometimes you can relieve this with some therapy, but a lot of times it's mainly just with medication. All right, on 897, so those are arthropathies, arthropathies, and then it goes into tendons, tendon sheaths, and bursa, osteopathies, and chondropathies. I say chondropathies, I guess. That's the right way. Anyways, that third one is osteomalacia. So osteomalacia, if you're remembering back to medical terminology, that's the softening. Malacia is softening. A softening of bone caused by loss of calcification of the bone matrix. Okay, osteomyelitis is inflammation and infection of the bone and bone marrow, usually caused by bacteria. Staphylococci are the most common causative bacteria. So under osteomyelitis, you need to write that osteomyelitis is usually from a compound fracture. And if you want to abbreviate fracture with FX, that's how we say fracture. But the osteomyelitis is acquired usually from a compound fracture. Okay, under the note, second sentence, the infection can spread to the bone through the blood from a previously injured site, or the microorganism can infiltrate the bone directly following open fractures, surgical reductions, or other exposures to the air. Okay. The next one's avascular necrosis. If you want to, you can read up on that. That's a pretty common one also, but as far as exam purposes, for this unit, I don't need you to know that. And then it talks about osteoporosis. You can read about osteoporosis. So on the next page, there's acquired deformities of the toe. That first one is bunion. These are very common. A bunion is a bony protuberance on the medial aspect of the first metatarsal. The condition is associated with hallux valgus. Valgus, I do not have that definition, but you can look that up in MindTap. So that is a hallux valgus deformity. A bony prominence projecting from a bone is called an exostosis. And sometimes you'll see those on the surgical, as a surgery, you're doing an exostosis removal. And that's what you're doing right there. Okay, then it talks about acquired deformities of the hip, deformities of the leg. You can see bow-legged, what that looks like on 899, what we're talking about when people are bow-legged. The congenital anomalies, the injuries, all sorts of things. So if you are loving orthopedics, you need to say yes to this whole chart, okay, this table. All right, but we're going to look at the injuries. That continues on to 900. So that injury at the top of 900 is fracture, but I want you to know in the description that note that most fractures are caused by accidents, although some are pathological. Okay, so like if you have a diseased bone, or if you've ever seen that movie, I think it's called Breakable with Samuel L. Jackson, where there's a congenital disease that you're born with, and they call them glass babies because they can fracture so easily. A lot of times when they're coming out of the birth canal, they already have like 3 or 4 fractures, and they usually don't live very long. It's like osteogen. Oh, I can't remember. When my husband comes in, I'll have to ask him. So, okay. Next is the classification of fractures. And you can see the types of fractures on 901, that figure 21-14. You need to highlight that because you're going to need to know all of those fractures. Okay, but here are some more fractures under the classification of fractures, where it starts with avulsion through and through. There's bucket handle. Now, a lot of times if you hear bucket handle, you'll think of the meniscus whenever you're doing a bucket handle meniscal resection during a knee scope. They have a bucket handle tear. What that means, if you look at a bucket and the handle, how it makes that, like the 3 sides of a rectangle, that's what it is. So you have a 3-sided rectangle tear or fracture. Next to butterfly, a butterfly is associated with comminuted, which means that, so comminuted is a type of bone fracture consisting of 3 or more fragments. So a butterfly fracture, and they don't have that on the next page, but is 3 or more types of 3 or more fractures, the butterfly-shaped piece of a fractured bone. So it's caused by direct or rotational force. Okay, and then on 901, that transcervical, make sure that you know that the cause of a transcervical fracture is direct force on bone. Okay, but you can see your different types of fractures, your green stick, spiral, and transcervical. I need you to look at D. Look at how the stellate fracture is asterisk shaped. Make sure that you know that. Sounds like a test question. If I ask which fracture is asterisk shaped, I can't say that word for some reason, you're going to say stellate fracture. Okay, there's comminuted. See how it's 3 or more fractures right there in F. Impacted, just as it sounds. Compound is broken in 2 spots. A Potts fracture right there, and then the Colles, which we will talk more about the Colles fracture here momentarily. Okay, and then the last part of this table on 902. Under the malignant neoplasms, there's multiple myeloma, but I need you to know the description. So malignant neoplasm of the marrow plasma cells resulting in bone destruction and overproduction of immunoglobulins. Okay, so that's what causes that multiple myeloma. But the benign neoplasms, make sure you know all 3 of those. So there's chondroma, giant cell tumor, and osteoma. Those are your benign neoplasms. Okay, so we're on page 903. So top left under types of fractures, that second sentence, fractures are either complete, in which the fracture completely interrupts the continuity of bone, or incomplete, in which the fracture is partial and some of the bone is still intact. Okay, so let's talk about the normal bone healing. So there, past that first paragraph, the normal process of bone healing, which is osteogenesis, and osteogenesis is development of bone tissue. So that involves the following 5 stages: inflammation, cellular proliferation, callus formation, ossification, and remodeling. Okay, and you can read all about that, but I just need you to know that there are the 5 stages right there. All right, so now we're on 903, the second column under pathological bone healing. So, and like it says on this slide, disruption at any stage can be responsible for a variety of abnormal conditions. So that first one in red, distraction. So distraction is separation of joint surfaces by extension without injury or dislocation of the parts. So what it says here in the book, it's a term used to describe bone fragments that are separated so that bone contact does not occur. Okay. Okay. So what that means is like if you have a break and with some traction, like let's say you get your, I don't know, like your arm got caught into something and it broke, but it still has some traction on it. Some soft tissue, like some muscle or some tendon, could kind of like put itself in between those two fractures, and then so it's a distraction. Um, and so the bone cannot heal properly if there's any soft tissue or malalignment with that bone. Okay. The next one in red, that avascular necrosis, that is the consequence of temporary or permanent cessation of blood flow to the bones. The absence of blood causes the bone tissue to die, resulting in fracture or collapse of the entire bone. Okay, so what it says here is avascular necrosis occurs when the capillary network or collateral circulation cannot be reestablished following a traumatic injury or when the vascular system is disrupted by other means. Okay, you'll see this a lot like in the hip joints, if they have avascular necrosis, especially if they have juvenile avascular necrosis, that means that you have a young patient getting a total joint because they do not have good circulation due to usually a traumatic injury. All right, compound fracture. So the compound fracture is a fracture in which a bone fragment punctures the skin and exposes the bone. It's also referred to as an open fracture. These are your emergency, truly getting called in fracture. So a compound fracture compromises the integrity of the skin and allows for the possible entry of microorganisms which may cause infection of the bone and injury to surrounding soft tissues. And then at the bottom of that paragraph, osteomyelitis, a serious infection of bones, starts as a local infection and can lead to chronic osteomyelitis. Okay, so we have stuck through the skin, or getting dirt or poop or anything else that's outside on our bone, and now this is truly an emergent case. All right, the next one in red, the delayed union. Delayed union is a delay in the healing of the ends of a fracture. Okay. And then non-union, that is failure to unite, as in a fractured bone that fails to heal completely. Okay. It says when the fractured bone ends do not unite, the presence of infection and movement of the fracture site are what usually cause non-union. Okay, next on the next page, 904, malunion, the joining of the fragments of a fractured bone in a faulty position, forming an imperfect alignment, shortening, deformity, or rotation. Okay, so malunion occurs when the fracture heals in a position that does not resemble the original anatomical form of the bone and alters the mechanical function of the bone. And then the last one in red is the compartmental syndrome. That is elevation of tissue pressure within a closed fascial compartment, causing a decreased arteriovenous pressure and decreased muscular perfusion. Okay, so it says that this is an increase in pressure within a closed space that usually occurs in the forearm and tibia. And then further down, tissue viability may be affected, increasing the risk for infection, and permanent nerve damage can occur. So at the end of that paragraph, you need to write emergency. The compartmental syndrome is an emergent situation. You have to get there to relieve that pressure, kind of like burr holes, where if you have a lot of swelling, you're going to have a lot of brain damage. If you have a lot of swelling in the muscle, you're going to have nerve damage, which could lead to a lot of neuropathy or needing to sever the limb if you have other complications. So this can become an emergency. Okay, next paragraph. About about 2/3 of the way down, when the circulation is compromised, the muscles become ischemic. So this is talking about compartmental syndrome. Necrosis begins in 2 to 4 hours and becomes irreversible in 12 hours. Nerve damage starts within 30 minutes, and after 12 hours, if the swelling is not stopped, there will be irreversible loss of muscle function. So you see why this is an emergency. Again, you have 30 minutes to stop that nerve damage before it becomes a permanent situation. Okay, I should have stayed on the last slide, but I'll just keep on going on this one. All right, so we're on immobilization. A cast is one of the more common methods utilized to immobilize a fracture. And then next paragraph, fiberglass and plaster are the most frequently used types of casting material. And you can see the advantages versus the disadvantages there between fiberglass and plaster. I know the majority of people at RVO use the plaster because it is cheaper. But fiberglass is lightweight. Like you can see, it's lightweight. You can write on it. It's really cool. You can write on plaster, but you can have the different colors on fiberglass. So the kids really like the fiberglass casts. Okay, now we're over to 905, the diagnostic procedures and tests. But before we get to that, there's that table 21-3, top right corner, types of casts. Put a big old star next to that. You need to know your different types of casts. The short, long, short arm, short leg, long leg. Those are pretty self-explanatory, but make sure you know that hip spica cast. These are your hip fractures in children usually. You see them in adults, but more so in children. And so these are glorified diapers. They're like casts that look like diapers. Okay. All right, so on to the diagnostic procedures and tests. At the bottom of that first column, the C-arm is a convenient fluoroscopy machine that can be directly positioned over the operative site. So we are using C-arm a lot. That's why we have to know how to drape our C-arms. Okay, and you can see a picture. Actually, you can't. I thought they had a picture of the C-arm on the next page. Never mind. Okay, so here we are talking about equipment on 907. You can see the basic orthopedic instrument set right there. And all the things. If you have, we're going to go through this in class, but right now, if there's an instrument on this page that you have no idea what it is, put a star or like a dot or some marker on it, and I will either show you a picture in class, or we'll discuss it, or we'll pull it out in the lab. We may have it. You never know. But if you continue through the pages, on page 908, 909, there you can see all your instruments. J, that's a lead hand. A lot of times they'll use a lead hand to hold the fingers open, to hold the hand open, like if they're doing any kind of Z-plasties or anything on the palm, they need to have those fingers extended. They'll use the lead hand. Okay. All right, the routine equipment on page 912. Let's see, under the positioning devices, fourth paragraph, the lateral position is frequently used for operations on the hip and shoulder. Okay. Yep. And then next paragraph, the prone position is used for procedures on the back, posterior portion of the shoulder, and Achilles tendon. Next paragraph, a fracture table is commonly used for surgery on a hip fracture and for femoral nailing. And please, when we're referring to that word femoral, please be advised it is pronounced femoral, not femoral. You will have surgeons jump on you if you pronounce it femoral. That's a rookie mistake. All right, next column under pneumatic tourniquets, about 2/3 of the way down. To avoid a pressure-induced injury to the nerves and blood vessels, continuous tourniquet pressure should not be applied for more than 1 hour on an upper extremity or for more than 1.5 hours on the thigh, which we discussed in the lab Hopefully you can remember all of that. Okay, then it talks about traction and then airflow systems, like it says on this slide, which continues on to 911 up at the top. Laminar airflow systems provide highly filtered air, one direction flow of air, and continuous air exchanges that reduce the microbial count. So if you have good laminar flow, 9 times out of 10, that's going to be your total joint room. So like at Mercy, you have room 6. They have excellent laminar flow systems. It's newer. Room 3, you could do some total joints in. So the bigger the surface area of the room, the more available, more areas of laminar flow you can install into the ceiling because you have a larger area. And so that's usually your bigger bone cases. Okay, I should have kept going on that last slide, but that's okay. Okay, so we have continuous passive ROM machines. So at the bottom of that first paragraph, the CPM provides the following advantages. You need to know number 1. It aids in decreasing pain and swelling at the operative site. So these are machines that you put your leg in or put your arm in, and it's going to manually move your leg for you to always have that passive range of motion. So that it does the work for you, so it can decrease the swelling and the pain, and so you can take your brain out of it a little bit. All right, the TENS units, the transcutaneous electric nerve stimulation units, also known as the TENS unit, can be used to suppress postoperative pain by stimulating large sensory nerve fibers. And man, do they work. If you ask anyone that owns a TENS unit, I have one. I can bring it to class if I need to. If you know anybody that has one and you put it on, it feels like little electric shocks, but it's not a bad thing. It's actually a good thing. It's a good feeling. It helps reduce pain. All right, saws, drills, and reamers. So we're still talking about routine equipment for orthopedics. All right, third paragraph. 2 directional terms must be understood in relation to the use of power saws. So an oscillating saw is one in which the saw blade moves side to side or oscillates like an oscillating fan, how it moves side to side to get both sides of the room. Oscillating saw, back and forth. In a reciprocating saw, the saw blade moves back and forth or reciprocates. So in a reciprocating saw, it's moving, let's say, in and out. And I'll show this to you in class. So oscillating is left to right. Reciprocating is in and out, like you're sawing a piece of, like a log, how you go in and out with a saw, same thing. All right, arthroscopic equipment. The required equipment includes, make sure you know 1 through 7 on your arthroscopic tower. You have your video monitor, the light source box, your arthroscopy pump and tubing for fluids, powered shaving system, camera system, video recording system, and photograph system. Okay, so now we're under routine supplies. Let's talk about implants. So the second paragraph under implants, the US FDA requires proper documentation and tracking of implants. Any implant, anything you put into the body, we have to track it for legal purposes and make sure that if you do get an infection, we can track it to see which serial number it was, the manufacturer, the expiration date, etc. Okay, that's as per the USDA. Excuse me. FDA, not USDA, FDA. All right. All right, the next page talks about suture. That table 21-6, suture used in orthopedic surgery. Let's talk about these. You can see the most common ones. There's fiber wire at the top. Make sure that you know surgical steel. Okay, and then polyester, which is Ethibond, which is your orange box. That is used on tendon to bone. So your Ethibonds are tendon to bone. Polypropylene or Prolene, your blue, purpley blue sutures, that's used on tendon to bone. Nylon or Neurolon, that's tendon to bone. And then polyglactin or your Vicryls, that is used only on periosteum. And so I wrote the words only on next to periosteum. That's the only time you're going to use Vicryl on bone is on the periosteum. Now, of course, you can use it on soft tissue, but regarding bones, it's only on the periosteum. Okay. Polymethyl methacrylate, or PMMA at the bottom left, also referred to as bone cement, is routinely used during total joint arthroplasty. Further down, the majority of ORs have incorporated the use of a closed mixing system that is attached to suction to exhaust the fumes created during the process of mixing the cement. Now, if you're going to write a paper that you are using bone cement in, make sure that when you document it, that you're putting it under both a medication and an implant. So you'll have to do A through I on medication for that bone cement, and it's also an implant, okay? Okay. And then it talks about other routine supplies. Okay, so we're going to spend some time on this slide because these are the surgical procedures of the shoulder. So we're starting on 9:13. This is where the meat and potatoes of orthopedic surgery comes into play. So let's talk about the shoulder arthroscopy, and of course we're going to start with the surgical anatomy of the shoulder. Okay, the clavicle, also known as the collarbone, you can feel your clavicle right there, is a long, slender, doubly curved bone that acts as a brace for the scapula and aids in keeping the shoulder in place. And you can see the clavicle right there on that x-ray at the bottom left, and you can see that in that diagram on B. All right, next bullet. The scapula or shoulder blade is a broad, flat, triangle-shaped bone located on either side of the upper back, forming the posterior portion of the shoulder girdle. And then you have your three sub-bullets. Make sure you know that third sub-bullet with the red. Between the processes on the lateral side of the scapula is a fossa called the glenoid cavity that serves as the socket for the head of the humerus, which we talked about in the ball and socket. So it says this forms the ball and socket shoulder joint. And the shoulder joint is the ball and socket joint composed of the head of the humerus that rests in the glenoid fossa. All right, and that's talking about the pectoral or shoulder girdle, but I need you to know those three sub-bullets in the third column. Of the three joints, the glenohumeral has the widest range of motion. The AC joint, and AC is acromioclavicular joint, so that's a part of the pectoral girdle located at the top of the shoulder that is an articulation between the lateral end of the clavicle and the flattened small process located on the border of the acromion. So the AC joint located at the top of the shoulder. Yep, I just read that. Okay. All right, so surrounding the shoulder joint are four muscles collectively referred to as the rotator cuff. And if you are ever in a shoulder scope and you can tell your surgeon that, hey, I know what makes up the rotator cuff, it is the infraspinatus, make sure you pronounce it properly, teres minor, subscapularis, and supraspinatus. They will not forget your name at all. If you can tell the four muscles of the rotator cuff, you are an orthopedic wizard. Okay, next page, continuing on, the main function of the rotator cuff is to provide stability and strength to the shoulder joint. All right, the humerus is the longest and largest bone in the upper extremity. It extends from the scapula to the elbow. And then that third sub-bullet in the second column, lying in a deep groove between the tuberosities called the bicipital groove, is the tendon of the biceps muscle. Okay. All right, and then that sub-bullet under that last bullet, procedures that can be performed include the removal of loose bodies, bursectomy, rotator cuff repairs, labral tear repair, and repair of impingement syndrome. Excuse me. Okay. So under the preoperative preparation, make sure that you know what position we are positioning these patients for a shoulder scope. We are in the lateral or semi-Fowler or beach chair position or the surgeon's preference. Sometimes they're in lateral. I know Dr. Bradshaw likes to do them in lateral, but the rest of them typically are in beach chair or the semi-Fowler's position. Okay, under practical considerations, that last bullet, the surge tech may be asked to rotate the arm for visualization of the shoulder joint. The surge tech should know the directional terms and know how to manipulate the arm and shoulder in the correct direction. So that's referring back to that table of the directional terms. Okay, so now we're into the procedure. So number 5, the procedural consideration. The surgeon will frequently use the arthroscopic probe, also called a switching stick, placed through the anterior port to examine the stability of structures as well as to determine if an injury such as a tear has occurred to the structure. You'll be using the probe a lot. All right, number 11, the surgeon moves the scope back to the posterior portal to examine the subacromial bursa for impingement syndrome and inflammation. So I'm wanting you to know that before we're done, that they're going to look at the subacromial bursa to make sure that nothing is impinging or hitting that area. And then number 12, one of the last structures to be examined is the AC joint through the anterior and posterior portals. If a bone spur is discovered, the arthroscopic ESU and shaver will be used to remove it. Okay, and we'll talk more about that in our class. All right, so that takes us to the open Bankart procedure. So the anatomy, the shoulder joint has a cuff of cartilage called the labrum that lines the rim of the glenoid. The labrum provides additional cushion to the joint as well as additional stability. A Bankart lesion is an avulsion or tear injury of the anterior capsule and labrum of the glenoid rim known as the inferior glenohumeral ligament. It is usually caused by subluxation or luxation of the joint. Okay. Under practical considerations on 918, there are several types of procedures for the repair of recurrent anterior dislocation of the shoulder joint, including the Putti-Platt and Bristow, as well as variations of the Bankart. So you can see down below there's the position and draping. You're using shoulder drapes, no drape towel, and you have a stockinette over the arm to protect the hand, to cover the nasty fingers. Okay, just the shoulder is exposed, but the whole arm is prepped because we'll have to move that arm. All right, then it continues to talk about the Bankart, but in an arthroscopic view with anchors. It's pretty much the same thing, but they're using anchors, which we're going to talk more about in class. But that takes us to page 922, the open acromioplasty. So under pathology, candidates for an acromioplasty are afflicted by an impingement syndrome which limits the ROM of the shoulder. And then that last bullet, the cause of the syndrome is the impingement of the rotator cuff between the humeral head and the coracoacromial arch during forward flexion of the shoulder joint. All right, preoperative preparation, you are in the semi-Fowler's position or beach chair or sitting position. All right, and then we're in the surgery. Number 7, the procedural consideration. So every few seconds, the surge tech should place a few drops of irrigating fluid into the area being resected to keep the saw blade and bone from overheating. Now, again, when we talked in neuro, we were talking about bone doing burr holes or anything with a saw or a burr or a drill. You're wanting to just gently irrigate to prevent that friction, that overheating of that tissue, which could spread and cause damage to that bone tissue. All right, and again, it's reiterating on page 924 up at the top, that pearl of wisdom. Small amounts of irrigation fluid are dropped onto the bits of power drives that are used to create the trough. The water prevents overheating and damage to the bone. So then the next procedure is the acromioplasty, and that's the arthroscopic. Again, it's the same thing, just like in general surgery. Anything open or anything laparoscopic can be done open. Here in orthopedics, anything arthroscopic can be done open as well. So it's the same things, but now you're just going underwater. But that does take us to 925, the total shoulder arthroplasty. So under pathology, the primary pathology for performing a total shoulder arthroplasty is chronic pain from glenohumeral arthritis with significant loss of ROM and joint function. Next bullet, another cause is when rheumatoid arthritis causes destruction of the cartilage or labrum of the joint. And then the last bullet, osteonecrosis of the humeral head is another reason for performing an arthroplasty. So we have dying bone, we could have some bad circulation, we need to replace that whole joint. And you can read all about a total shoulder there. Okay, so now we are on page 928, procedures of the radius. And the first one is the most common, an external fixation of a Colles fracture. A Colles fracture, so an X-fix is not the most popular, most common now, but it's a very common fracture, the Colles fracture. These are people that are breaking their wrists. They're catching themselves when they fall, etc. So under the anatomy, the radius extends from the elbow to the wrist and rotates around the ulna. An easy way to remember which side of the arm the radius lies is to recall that it is on the same side of the arm as the thumb. So radial equals thumb side. So I have that written in that little blank area. The radius or radial equals thumb side. What I like to think is I say PU, like PU. P for pinky, U for ulna. So PU and then RT, radial thumb. Okay, that last bullet, Colles fracture is an angulated fracture of the distal radius at the epiphysis approximately 1 inch from the wrist joint. And yes, we need to know 1 inch. Okay, on page 929, you have a great picture of the hand and wrist joints 1 through 7. You need to know all 7 of those because if you ever work with Dr. Kelly, who has a hand fellowship, you will see on the schedule like DIP or PIP, things like that, a CCM, MCP, you'll need to know these abbreviations. And if you've seen these on the board, you know exactly what I'm talking about. So you have your distal interphalangeal joints, your proximal interphalangeal joints, your metacarpophalangeal joints, your carpometacarpal joints, interphalangeal joint, radiocarpal joints, and intercarpal joints. Okay, make sure that you know those joints. And so if we're doing a fusion or like putting a pin or like a wire down those joints, we need to know if it's PIP, DIP, etc. Okay. Okay, so you can see on 931, that's what an X-fix looks like. Some people call it external fixator. Some people say external fixator. But it is a device on the external part of the arm. So you're making just little small poke holes and you're putting these implants in, and then you're going to have to wrap your dressing around this apparatus that's on the outside of the limb. Okay, you can have X-fixes on legs and arms, but this one is for the Colles fracture. Okay, so that's going to take us to 932, the ORIF of the radius. I need you to know under the surgical procedure number 7, second sentence, using the drill and drill guide, the first hole is drilled, the hole nearest one end of the bone is drilled first, tapped. If self-tapping screws are used, it's not necessary to tap the drill hole, and the depth gauge and screws are placed. The surgeon will place one screw at a time. So this will make more sense after I demonstrate the ORIF or the small frag set to you in class, okay? Just make sure that you know that order. So your drill, depth gauge, screw. Drill, depth gauge, screw. It's the same all the time. Okay. The next page, I think I have this highlighted. I'm pretty sure I can, yeah. All right, on 934, that pearl of wisdom. Two of the main categories of screws available are self-tapping and non-tapping. So other types of screws available include cannulated, locking, and non-locking. So self-tapping screws can be identified by an angled notch near the tip of the screw, which I'll show you. Non-tapping screws require that the drill hole be tapped with a tapping device prior to placement of the screw. You must be able to identify the difference, which I will show you, okay? All right, so that's going to take us to the ORIF of a hip fracture. All right, so here comes the anatomy. The sacrum, coccyx, and pelvic girdle form the circular pelvis. Second sub-bullet, the pelvis is created from the fusion of three bones called the ilium, ischium, and pubis. Third bullet, or that next primary bullet, that's in the second column up at the top, the ilium flares outward in a ridge called the iliac crest. And you should remember this, the crest serves as a primary site for obtaining bone for bone grafts. The ischium forms the inferior portion of the pelvis and is the strongest of the three pelvic bones. And then the last bullet, the hip is a ball and socket joint formed by the deep round fossa called the acetabulum, there it is, located in the innominate bone and the head of the femur. And I underlined the word head. Okay, located in the innominate bone and the head of the femur. Okay, and then it continues on to 935. There's that last sub-bullet, but all the way on the right, the operative fractures that require ORIF are intertrochanteric, subtrochanteric, femoral neck, and basilar neck fractures. Fractures are common in the elderly and in females who have osteoporosis. Next bullet, the following discussion is for repair of intertrochanteric fractures used with the use of the AO dynamic hip screw or the dynamic condylar screw, or which is the DHS or DCS system. Now, going back to that prior page, you can see there's a great drawing of the bone and the X-ray for the hip bone. Okay. Understand though that usually for like nowadays, this book was published, I think in 2018, and even back in 2018, the TFN, the trochanteric femoral nail, that's a very, very popular, very common way to fix a broken hip. Okay, a hip fracture. So the DHS system is a little dated, but we'll still talk about it. Because it doesn't, you may travel somewhere where they're still using the DHS or the VHS system. Okay, so DHS, under the equipment and instruments, that second column, dynamic hip screw, which is DHS, those are your specialty instruments, and then your DHS implants will be used. In the preoperative preparation, the position, you're going to be using a fracture table with the patient in the supine position to reduce the fracture. And if you have not seen these tables, I will pull up a picture of a fracture table. So the unaffected leg is in a stirrup, and the broken leg is stretched outward, and then so they're going to be in a elevated table. It's on the elevated table, like right up to where your face is. And so the surgeon may stand, they may sit, but you're going to be working on the lateral portion. Okay. All right. That takes us to 939, the total hip arthroplasty, the posterior lateral approach. So under pathology, the primary indication for total hip arthroplasty, or THA, which is the abbreviation, is decreasing the incapacitating pain in patients who are older than 65 years of age and for whom the pain has not been resolved by conservative medical therapy. So these are people that have tried injections, they've tried physical therapy, they've tried hip scopes, arthroscopies, and so now we are to the point where we need a total hip. All right, so under the practical considerations on page 941, second column, some surgeons may have the team remove the outer gloves of the double gloving and replace after draping. Studies have shown that the highest risk for breaks in sterile technique during orthopedic procedures is during draping due to the complicated draping procedures. So this is why during any total arthroscopy or total arthroplasty, whether it's knee or hip, that they will take off their top gloves and then you will don a fresh pair of outer gloves for the surgeons and for their assistants after they have done the draping. You can see an implant on 941. There's that implant with the new acetabular socket right there. There's that new femoral head, that ball, and then the shaft that goes down into that femur, the femoral component. All right, on 942 under the surgical procedure, number 1, a posterior-lateral approach is the most common approach to the hip joint. And you can read all about that. Right there in 945 at the top, you can see the femoral reamer. And you do a lot of interchange, like you'll change out the acetabular reamers and the brooches that go down into the femoral canal as well. It's quick. So that is you and your rep having good communication in order to do one of these. And then you can see on 947, that's what it looks like with the prosthesis in place. Okay, so we've completely taken apart that joint and have replaced it with an implant. Okay, so on 948, we're now onto the femoral procedures. So there's the repair of the femoral shaft fracture with AO titanium femoral nail system. So here is your TFN right here. Okay. So under the anatomy, the femur is the largest bone in the body, extending from the hip to the knee. The proximal end of the femur consists of the femoral head and neck around the greater and lesser trochanters. Next bullet, at the distal end of the femur is the lateral and medial condyles that articulate with the condyles of the proximal portion of the tibia to form the knee joint. The femoral condyles are separated by a depression called the patellofemoral groove that forms the articulating surface for the patella. Okay. All right, so on 949, we're still talking about the anatomy. So that last bullet up in that section in the third column, halfway down, it says types of nails include flexible nails. So we can use a flexible nail. And then at the bottom, then you can also use the intramedullary nails and standard nails such as the AO, which is a surgical procedure description, is the AO titanium femoral nail system. Okay. All right, under the equipment, you're going to be using your fracture table again for the TFN. And then under your position on 950, a fracture table is used with the patient in the supine position to reduce the fracture. Okay, so now we're on page 952 under your knee procedure. So we've done shoulder, we've done radius, we've done hip, now we're on the knee. So the first procedure is the arthroscopy of the knee joint with repair of torn meniscus. So the anatomy, you have the patella, that's a sesamoid bone which we discussed. In the second column, second bullet, 2 large ligaments, and a ligament is a band of fibrous tissue composed of collagen that connects bone to bone, not tendon to bone, it's bone to bone ligament. So two large ligaments located in the knee joint help stabilize the movement of the joint. These ligaments are called the anterior and posterior cruciate ligaments, so ACL and PCL, and are located in the intercondylar region of the knee joint. Okay. All right, and that last bullet in the last column at the bottom, a common injury of the knee is a torn ACL, which requires surgery to either repair or replace the ACL. And you have a beautiful depiction of that on 953. In fact, I have it highlighted at the bottom. In the between, it says posterior cruciate ligament and anterior cruciate ligament, how they cross. That means cruciate is cross, Latin for cross. Posterior is behind, anterior is in front. Okay, and again, ligament is bone to bone, so it's connecting the tibia to the femur. Okay. All right, so we're continuing the surgical anatomy on to 954. The knee joint is cushioned to withstand activities such as walking, jumping, and running by a pair of menisci called the lateral and medial meniscus. Okay, those are your shock absorbers. Third bullet, the tibia or shin bone is the larger, thus stronger bone of the lower leg. It is located on the medial side. Located at the proximal end of the tibia are the medial and lateral condyles that articulate with the condyles of the femur to form the knee joint. Distally, the tibia articulates with the talus bone, forming part of the ankle joint. Laterally, it articulates with the fibula, which is on the outside, the lateral part, which is attached to your little ankle bone. The medial prominence of the ankle joint is called the medial malleolus, not malleolus, it's malleolus. The fibula is located on the lateral side of the lower leg. It is a non-weight-bearing bone, that's why it's so tiny, that serves as a site for attachment of ligaments and muscles of the lower leg. A prominence called the lateral malleolus articulates with the talus bone to form the other portion of the ankle joint. All right, on 955, continuing, knee arthroscopy is performed for diagnostic purposes, for removal of loose bodies that can cause the knee joint to lock in place, for shaving the patella and torn meniscus, and for insertion of instruments to perform a meniscectomy or repair. Injury to the menisci is one of the most common knee injuries. Various types of tears can occur in the meniscus, the most common being what is called the bucket handle, which we kind of talked about. The bucket handle consists of an incomplete longitudinal tear with the displacement of the inner portion of the meniscus. When a tear of this type is encountered, an arthroscopic partial meniscectomy or repair can be completed. You can hear my daughter in the background. Hey, while you're here and while I'm recording, what is it called whenever infants are born with glass bones? What is that called? Is it osteogenesis imperfecta? Of course, I remembered it right whenever I could not remember it whenever I saw you outside. I'm like, osteogenesis imperfecta. Okay, thank you. Okay. All right. I apologize for my family in the background. Okay, so you can read all about the knee arthroscopy. We will talk more about this in class. But that takes us to 959, the ACL repair. All right, so under the anatomy, that fourth sub-bullet in the middle column, it is an important stabilizing structure, talking about the ACL, and the most frequently injured ligament of the knee. Okay, on page 960 under the preoperative diagnostic tests, third bullet, or that last bullet halfway down, ACL repair involves replacement of the ligament with autograft, synthetic ligament, or allograft. Autografts are most often used and include patellar tendon graft, which is the most frequently used, iliotibial band, or semitendinosus tendon. A lot of people will say semi-T. Okay. Okay, on 961 under the surgical procedure number 3, there are two types of grafts. Autograft, which is a graft taken from the patient's own tissue, so it's an autogenous, or allograft, which is a tissue taken from another person, which is a cadaver, okay, which we should know the difference. Okay, on 962, number 5, so if we're harvesting, if we're taking an autograft, we're going to have to harvest. So we're going to do the hamstring harvest and preparation. So make sure you know letter B. The semitendinosus and gracilis are identified. These are the tendons that will be harvested to create that ACL. And you can see what the ACL preparation looks like at the top. That looks like it's from a cadaver. Okay, so that's autograft. Allograft, which is number 7 on 963. A, make sure you know the second sentence. The types of allografts include patella tendon, Achilles tendon, and anterior tibialis tendon. Okay, so that's what you're going to go to your deep freeze for, your anterior tib. And that takes us to 964, the above the knee amputation, also known as an AKA. So that first sub-bullet, diabetic patients who are prone to non-healing ulcers and poor vascularity to the extremities are at risk for amputation, in particular of the foot and leg. Okay, so these are really bad diabetic people. They have bad neuropathy, bad circulation. We are going to do an above the knee amputation. And you can see the different instrumentation that we use on 965. A lot of times we're using a power saw, but we can still use like that giggly saw. Make sure you know what a giggly saw is. Okay, so that is in contrast to 967, the BKA, below the knee amputation. And so that takes us to 969, the total knee arthroplasty, or TKA. So under pathologies, the first sub-bullet, the normal surfaces may have become damaged due to disease such as degenerative joint disease or through years of wear and tear such as in athletes who are involved in impact sports. So your football players, wrestlers, your gymnasts, the people that are constantly having a lot of impact on them are setting themselves up for TKAs in their 50s and upward. Okay, under the equipment, make sure you know in that second column at the bottom, you have a cement mixing system. And we'll talk more about this. Okay, but it is believed that as of now, still, if we have someone pregnant in the room, they are to go outside of the OR when we are mixing cement because that methyl methacrylate fumes could cause some birth defects. All right, under practical considerations on the next page, second column, that first sub-bullet, knee implants are divided into 3 different categories based on the section of the knee to be replaced. Unicompartmental, bicompartmental, and tricompartmental. Unicompartmental implants are used to replace either the medial or lateral side of the corresponding articular surface of the femur and tibia. Charlie, please hush. Bicompartmental implants replace the medial and lateral surfaces of the femur and tibia. Shh, hush, honey. Tricompartmental implants replace the medial and lateral surfaces of the femur and tibia, including the patella. Just don't shout, honey. Okay. All right, on 971, the surgical procedure, number 1, make sure that you know A. An anterior midline skin incision is made with the knee in flexion. Why do we flex the knee? Well, because if you have your leg extended and they have a lot of fatty tissue or loose tissue, when you make that incision, the scar is going to be all zigzaggy, whereas if you flex the knee, it's going to be really pretty. All right, and you can read all about the total knee, and they have lots of pictures on 976 and 977. You can see on that plate 21-7 the wear and tear on that femur, and on 21-4. And so these are all of the steps for a TKA. Okay, here we go. Last area. So now we're on down to the ankle and foot procedures. So the first one on 982 is the triple arthrodesis. So under the anatomy, that first sub-bullet and the third column, the largest of the ankle bones is the calcaneus, which is located inferiorly to the talus and forms the heel. Then the next bullet, triple arthrodesis is most effective for individuals suffering from a forefoot or hindfoot deformities. And then that last sub-bullet, actually no, go back up. My highlighter is just so faint right here, I think, yeah. So that first sub-bullet, such deformities are the result of clubfoot. Okay, so this is clubfoot. And then the last sub-bullet, the result of triple arthrodesis is the fusion of the subtalar, calcaneocuboid, and talonavicular joints. Okay, now you can see on 984 all the different bones that make up the foot, the tarsals, the metatarsals, and phalanges. You don't have to know all those, don't worry about it. Okay, but make sure on 985 you know that 21-39, that's a lamina spreader, very common in both neuro and ortho. Make sure you know what that is, the lamina spreader. All right, so that's going to take us to 986, the Achilles tendon repair. Second bullet, it is the thickest and strongest tendon in the body and is approximately 6 inches long. Okay. So on 987 in the preoperative preparation, we are going to be in the prone position. Okay, you can feel your Achilles as that thick, thick band right at the bottom of your foot. All right, 988, the practical considerations. First bullet, you're going to place the tourniquet while the patient is in the supine position before turning him or her in the prone position because it is difficult to apply the tourniquet in the prone position. And I think I demonstrated this in the lab when we were talking about tourniquets. All right, so under the surgical procedure number 3, several suture techniques can be utilized by the surgeon. One popular type is called the Krakow whip stitch, in which suture is placed 2.5 centimeters from the edge of the rupture to accomplish the approximation. The suture used to repair the rupture is the surgeon's preference. It can range from a 2.0 non-absorbable to a number 5 Ticron or Ethibond, but always on a non-cutting needle. And so that takes us to 989, the bunionectomy, our last procedure. So under the pathology, a bunion, medically referred to as a hallux valgus, is a bony exostosis located on the medial side of the first metatarsal head of the greater toe, causing a lateral deviation of the toe. Bunions are common in females due to the common shoe styles worn by women, including pointed toes and high heels. Okay, and then make sure that you know that third bullet in the second column. Various types of surgical procedures are used to treat the condition, such as the Aiken, Chevron, McKeever, Keller, and McBride techniques. And the Chevron and the McBride are very popular. Under the practical considerations, it is important to verify the foot that will be operated on. Patients often have bunions on both feet, and the foot with the worst deformity may be the only one operated on. So this is where the timeout is critical. And that sums up our chapter. Okay, to summarize, we looked at the anatomy and physiology of the musculoskeletal system. We looked at all the different pathologies and then all of the different procedures, equipment, diagnostic tests, etc. So now we will go to class and we will do a lot of hands-on activities to solidify this information in your brain. See you then.